With that being said, there are fascinating new developments and approaches in preventative care that hopefully we can build upon and make more available to everyone. This series is a great opportunity to discuss the latest developments in preventative medicine and consider what we, as policymakers and our constituents, need to be aware of. In the interest of time, we're just going to, the bios are available for each of our speakers, so we're just going to get started with Carter. So Carter, if you want to begin.
Okay, is the mic working now? Yes. Thank you. Good morning, Mr. Chairman. My name is Carter Harrison, and I am the Director of State Regulatory and Legislative Affairs for the Alzheimer's Association and the Alzheimer's Impact Movement. And I want to thank you guys for the opportunity to speak with you today about some of the changing landscape around Alzheimer's disease, risk reduction, early detection, diagnosis, and treatment. For those of you that are not aware, Alzheimer's is the most common form of dementia. It's a progressive brain disorder that basically destroys brain cells and leads to the loss of being able to do any of the activities of daily living, including eating, bathing, and managing your own bodily functions. This disease is devastating, obviously, for the individuals that have it, but also for their families and their caregivers. And Alzheimer's disease is always fatal. And on the screen, I have a couple of statistics that I hope can illustrate some of this problem. First, you'll see the lifetime risk for Alzheimer's disease for men and women. You'll note that women are twice as likely to experience Alzheimer's disease as men. Additionally, you'll note that 4 in 10 Americans are not ready to talk to their doctor about this, or excuse me, 6 in 10 are not ready to talk to their doctor about this, and 7 out of 10 would do it if there was a treatment that was available. And lastly, I want to point out the cost of Alzheimer's disease, and this takes the form not only of long-term care, for example, nursing homes, assisted living, but also home and community-based care, and just the toll on the society in general. The disease itself is very expensive, one of the most expensive in the country. So with that, you might be asking yourself, what can we do about that? So recent research has indicated that as much as 40% of dementia cases worldwide may be attributable to modifiable risk factors. And as a result of that, many of these factors, well, let me back up a second. Many of these factors that influence Alzheimer's disease are genetic or environmental and can't be controlled, but there are some that can be done to lower your risk. Observational studies show that people who practice healthy behaviors tend to have a lower risk of dementia. However, further clinical testing is needed. Behind you, you see a slide that deals with the US Pointer study. The Pointer study is a study to protect brain health through lifestyle intervention to reduce risk. And it is designed to test a multitude of factors that are interventions within some of the healthy activities to see which ones of these collectively will work in a diverse population, hopefully identifying ways to lower risk and then put forth guidelines that can help inform healthcare decisions and recommendations going forward. We are very excited as the Alzheimer's Association to be sponsoring this study, and we are looking forward to the results that should be out in 2025. In the meantime, there are a number of risk factors that can be addressed, and here we have an infographic about healthy brain, the 10 healthy habits for your brain. I'm sorry, the marketing people want to make sure I get that correct or else I'll be in trouble. And these are a number of areas where you can help control your risk or reduce your risk. One of the key ones here, I think, deals with high blood pressure. High blood pressure can have a serious impact on your cardiovascular system as well as your brain, and controlling that through simple means may help reduce your risk. Also, managing your blood sugar. This is one where the diabetes treatments can also help reduce your risk by lowering or maintaining a healthy blood sugar level. Also, maintaining a healthy weight. This is one where I, quite frankly, don't do the best job with. But if you can manage your weight appropriately, it does help to reduce your risk. Additionally, staying active physically and mentally is very important. So whether that be furthering your education or going out and doing your morning jog, very important to helping your risk factors. And then lastly, one that I think is probably obvious to folks, but I do want to highlight it, and that is protecting your head. A reduction in head injuries also correlates to lowering your risk for Alzheimer's disease. And while these interventions might prove effective in the future, currently there are nearly 7 million people living with Alzheimer's disease, and that number is expected to grow to 13.8 million by the time that 2060 arrives. For these millions of people, early access to a diagnosis is the key to reducing costs and reducing negative health outcomes. Many individuals experience memory problems and thinking problems, but put off seeing the doctor. You'll recall my earlier statistic there. And it's hard for me to believe that 60% of adults say they would not see a doctor right away if they are experiencing symptoms. And when I think about that, if I was experiencing symptoms of cancer, I would be in my doctor's office so fast to get diagnosed and treated. But for some reason, for things like Alzheimer's disease and other cognitive impairments, that is not necessarily the case. So this is where things have changed a lot in the last couple of years. When I was younger, my grandmother had Alzheimer's disease, and I remember going through the process of getting a diagnosis with her, and it involved going to the primary care physician and doing an assessment, and then 6 months later going to the primary care physician and doing an assessment, and then going to the primary care doc 6 months later and doing an assessment, never actually receiving a diagnosis, however, being put on what was a treatment drug at that point in time, which was Aricept. Unfortunately, there is still some of that occurs now. One of the ways that diagnosis occurs is observation of cognitive decline. Generally speaking, what you will realize when that happens is that the person gets worse over time, and by the time they're ready to receive a diagnosis, it might be too late for certain interventions that could have helped them earlier in the disease process. Now, the part that's changing about this is the science behind biomarkers. And NCOIL is very familiar with the discussion around biomarkers for certain, but I want to make sure that I spend a little time here talking about biomarkers for Alzheimer's disease. So of the list behind me, many of these are used in research and are not widely available, with a couple of exceptions. So the first is amyloid PET. That is where they do a PET scan and they detect amyloid in your brain. There are not a lot of amyloid PET scanners out there in the world, and so access to this is relatively scarce at this point in time, but it is available and it is an important tool for diagnosing people with Alzheimer's disease. Secondly, there is what we see up there is the CSF, which is a spinal tap, where they test your spinal fluid for the presence of amyloid. As you can imagine, there are not a lot of people running in line to go and have a spinal tap so they could be diagnosed with Alzheimer's disease, but it is an option and it is a way to get a confirmatory test. And I'll just sort of add to one of these that's on the list, tau PET. There is some research that's ongoing currently around this, not only from a treatment perspective, but also from a biomarker diagnostic perspective. And hopefully this will add to the list of ways to detect Alzheimer's disease going forward. That being said, the most promising of these diagnosis tools are blood tests. There are currently blood tests on the market now that can test you for amyloid. They have not been approved by the FDA fully. They're oftentimes lab-developed tests, for those of you that are familiar with that concept. And they are sometimes used in research currently, and they may, in the future, assuming they move forward and continue to make progress, be used in a clinical setting, which I think will change the way Alzheimer's disease is diagnosed in this country. And honestly, I feel like that is something that is possible to happen within the next few years, so it's worth considering moving forward from a policy perspective. So once you get this diagnosis, or sometimes not, there's a movement towards treatment. And there are two types of treatment that exist for Alzheimer's disease. And when I say this sometimes not, the story about my grandmother and being on Aricept sort of falls into that sometimes not category. So drugs like that only address the symptoms of the disease. They do not do anything about the progression of the disease. In other words, amyloid still builds up in your brain. You still lose cognitive function with time. Those drugs are guaranteed to eventually fail and not provide the kind of cognitive support that you're looking for. And then secondly, there are drugs that do slow the progression, according to the FDA. These are all infusion drugs currently. So again, when we talk about access, this is not a pill that you take at home. It's a lot more complicated process. These drugs, of course, have risks, and they require positive confirmation of amyloid, as well as follow-up tests to ensure that you don't have ARIA or other, which is a brain bleed, or other issues related to the complications from those drugs. So, when we think about early diagnosis, it's not just about access to care or treatment. It's also about what can be done for the individual starting at the earliest point in the process. So using biomarker testing will oftentimes allow the person to be early in the disease state before the consequences that I talked about earlier happen. This is when they are still cognitively relatively okay and can help participate in their plan of care. A lot of times, the cost impact and the negative health impact for Alzheimer's disease is based around a change in setting. So let me give you an example of what that would mean. I come home for Thanksgiving and I notice my dad is not doing well, and it scares me. So all of a sudden I get a little panicked, and I think maybe my father should be receiving some extra care, or maybe I think that he should be in an assisted living facility or nursing home. And that decision's made relatively quickly, and then the costs continue. But with early diagnosis and intervention, we can have those plans and discuss those issues with my father prior to his memory being bad enough that he actively resists or is not feeling like his wishes are heard in that process. Additionally, another area where we have cost issues as well as bad health outcomes is comorbid conditions. One of the things that I do for the association involves Medicaid and the management of MLTSS and care management programs. And one of the most astounding things that I have discovered is that diabetes management plans oftentimes do not check the cognition of the individual. Same thing with heart disease and some of these others. So you'll have a relatively benign or relatively straightforward plan of care that says you need to check your blood sugar X number of times a day, not knowing that the person is cognitively impaired and can't do that, and therefore they decompensate or they have issues with their diabetes, and that costs the system. They also have rehospitalizations. That's been a work in progress for some time, but it sort of shows how planning can help alleviate some of those costs and some of those bad care. Also, you heard me talk about transitions in care. If you can make a move one time, it's much better than having to multiply move an individual. So if you decide to go to an assisted living facility, if you make a good choice the first time, that's a lot easier than having to move them to yet another assisted living facility or to a nursing home or at home, however that process plays itself out. Also, there's an opportunity to deal with safety concerns. Many people with dementia wander. My grandmother was famous for showing up in the field. We lived on 200 acres, so her wandering was a little bit scary when we'd come home and not be able to find her. Or safety issues like leaving the stove on, operating the microwave with nothing in it, any of these kinds of things, not to mention driving. Again, from a rural community, driving very important. So ways to address these safety things. And lastly, I want to talk a little bit about cost savings. So throughout my discussion around early diagnosis and intervention, I've given multiple examples about cost savings, but this is where I think it gets a little bit complicated for people with Alzheimer's disease, because it is oftentimes thought of as a disease that impacts older individuals, so those 65 or older. And those costs are borne by Medicare primarily, and then to some extent by Medicaid as well. But as time moves forward and the science behind diagnosis gets better, those people are going to be diagnosed at a younger age. So pre-Medicare, possibly 60, maybe 55, I don't know. So those interventions that I've been talking about will be done on the private market side, but that cost savings will appear on the Medicare side of the house. And that further complicates the cost analysis of how to deal with Alzheimer's disease going forward. So with that, Mr. Chairman, I'll pause for any questions.
Any questions? Seeing none, let's move to Sharice.
Oh gosh, okay. Good afternoon. My name is Sharice Richard. I'm a Senior Director of State Policy for Pharma. I'd like to first start by thanking Dr. Oliverson for his stewardship in this panel series. We're really appreciative for the opportunity to be here today. So this slide here is just a quick look at Pharma's membership. We represent the leading biopharmaceutical manufacturers in the U.S. The progress that we are seeing within the industry today is truly remarkable. Science has never been more promising. Here we have some news headlines from entities like the CDC and CNN highlighting the recent impacts of vaccinations and treatments for diseases like HIV and hepatitis C. What used to be a death sentence is now manageable illness. Our members are at the forefront of innovation, with patients at the center of all we do. Medicines play a central role in making our healthcare system more sustainable. The progress made against COVID-19 since the start of the pandemic illustrates a very recent global example of how critical medicines are in overcoming our most pressing healthcare challenges. At the beginning of the pandemic, our hospital systems were overwhelmed, resources were stretched, and death rates were growing at an alarming rate. Today, we have several vaccines available to help protect against the virus and therapeutics that can help reduce its consequences. Importantly, we also have the means to minimize the extraordinary burden that formerly threatened to overwhelm our healthcare system. In fact, since the introduction of the novel COVID-19 vaccines, the U.S. vaccination program has been estimated to have saved 279,000 lives and averted up to 1.25 million hospitalizations. Medicines have the ability not only to improve and save lives, but they can help avoid other, often costly, healthcare services, such as emergency room visits, hospital stays, surgeries, and long-term care. There are three main buckets when considering mechanisms by which medicines reduce spending and improve health. First, the prevention of disease. The industry is always working to further innovate existing treatments. We see this with vaccines, which prevent infectious diseases and reduce hospitalizations. Next, we have the better management of diseases. Our industry is always working for innovation in existing treatments in addition to the creation of new ones. An improved formulation of an existing medicine that improves treatment adherence produces better health outcomes and thus decreases financial burden on the system down the line. Finally, the last bucket is curing of the disease, something our scientists and researchers strive to accomplish every day. For example, we can look at gene therapy. When a therapy corrects a malfunctioning gene, not only eliminating a genetic condition, but the costs associated with treating it as well. The economic burden of disease is substantial. So here comes that first bucket I mentioned previously, the prevention of disease. Vaccines could avoid billions of dollars each year. The annual costs associated with vaccine-preventable diseases like the flu are almost $6 billion. The COVID pandemic estimated total economic impact in the US is upwards of $6 trillion. That is twice as great as those of the Great Recession of 2008. Let's take a closer look at these preventable diseases and their impacts. Vaccines prevent and also decrease the severity of disease, which reduce overall healthcare costs for diseases like COVID, the flu, and whooping cough. COVID-19 vaccines prevented more than 18 million hospitalizations and nearly 3 million deaths in the first 2 years they were available. The flu. So the flu vaccine prevented an estimated 7.5 million cases, 3.7 million costly medical visits were avoided, and the prevention of 105,000 hospitalizations, which avoided over 6,000 deaths the year prior to the pandemic. Childhood vaccines produce significant savings as well. Every dollar invested in pediatric immunization results in a $7.5 savings for the healthcare system. The chart on the left highlights that those children without childhood immunization had an estimated cost of $63 billion among children born in 2017, compared to the drastically lower number from children that did have childhood immunization, with costs totaling $8.5 billion. This illustrates the direct impact on long-term healthcare costs prevention methods like vaccines can have. That second bucket, which is the better disease management, is reflected in the example with adherence. Optimal adherence to medicines for a range of chronic conditions like congestive heart failure and hypertension leads to reductions in hospitalizations for patients enrolled in Medicaid. So this chart indicates the reductions in hospitalizations due to adherence in Medicaid populations, with a 26% reduction in congestive heart failure hospitalizations and a 26% drop for those with schizophrenia or bipolar disorder. Research has shown that increased use of medicines among patients is associated with reductions in expenditures from avoided use of inpatient and outpatient services. For example, among Medicaid patients with diabetes, asthma, depression, hypertension, congestive heart failure, and high cholesterol, improving adherence could produce $8 billion in savings annually. In addition to savings from avoided medical services, better use of medicines also improves health and overall quality of life, leading to reduced disability and less missed days of work. For a more specific example of medicines in action, hepatitis C medicines produce savings in Medicaid. With the introduction of interferon-free DAAs into the market in 2013, by 2026, the cumulative amount of savings to the system is anticipated to reach $43 billion. The DAA agents target multiple steps in the HCV replication lifestyle. They are highly effective and safe and require a short-term treatment duration. So virtually all patients are suitable for DAA, including those previously intolerant or ineligible for interferon therapy. Another example of innovation in treatment, not only helping patients feel better, but alleviating pressure on the healthcare system in the long run, is cell and gene therapies, which are a part of a new era of treatments. They treat the root cause of disease, are potentially curative, and utilize one-time administration. When looking at a disease like hemophilia B and the health costs and patient burden associated with it, there is a current annual healthcare cost of $615,000 per patient, prior to the introduction of gene therapy. Once introduced, there is almost a complete reduction in factor replacement therapy, and the potential savings to the healthcare system the year following gene therapy is as much as $600,000 per patient. This is an incredible decrease in cost burden to the system and to the patient. Therapies like this offer patients independence, relief for caregivers as well as patients, and a hope for the future. I would be remiss if I didn't mention an assistance tool that pharma created called MAT, which is a medical assistance tool that helps patients search and learn more about over 900 cost assistance programs sponsored by manufacturers. So it's an intuitive tool that you can type in your health insurance information, your location, and the drugs you're looking for, and see what exists to help you throughout your treatment journey. So as you're all aware, and what I mentioned before, is that the economic burden of disease is substantial. And fortunately, where there are pitfalls, there are also tremendous opportunities to drive value in our healthcare system with prevention and vaccines, better disease management with adherence, and a focus on continued innovation towards the curing of diseases. Thank you.
Thank you. And for time's sake, we're going to hold questions till the end. So, Brian?
Thank you. My name is Brian Tysinger. I'm a research professor at the University of Southern California. I work at the Schaefer Center for Health Policy and Economics, where I direct the microsimulation team. I'm going to be talking about a handful of projects that we've done over the last 5 or so years that are quantifying the life course benefits of prevention, looking across a broad disease, set of disease areas. So the tool that I use to think about value of innovation and value of prevention is microsimulation, where we model individual outcomes over their life course. And so I'm not thinking about cost savings necessarily tomorrow. I'm thinking about the entire aggregated lifetime exposure to that kind of treatment. We use 2 microsimulation models. One's called the Future Elderly Model. The other is called the Future Adult Model, FEM and FAM. I'll mention those throughout the talk. And we use those to study a broad set of diseases. Initially, we worked around aging, but we've also done work around early childhood education, the benefits that has over the life course, adverse childhood events, the impact that has over the life course for adults, serious mental illness, obesity, and then chronic conditions like diabetes, hypertension, congestive heart failure, COPD, and others. And a lot of work on Alzheimer's disease as well. I would be remiss not to talk about that. So the microsimulation models that we work with, FEM and FAM, they track complex interactions between health, mortality, and economic outcomes. So we're not thinking of the value of prevention not entirely from just the health benefits, but the more extensive health-related economic benefits. So if an individual can stay in the labor force and earn money and pay taxes, we consider the value of that. So our models are based on nationally representative panel data. So we use the Health and Retirement Study and the Panel Study of Income Dynamics, which are nationally representative. They go back every 2 years and talk to the same individuals and ask them all sorts of questions about their health, but also a broad set of economic-related questions. Then what we do is we simulate individuals' risk factors, their development of chronic illnesses, their loss of function through functional limitations like activities of daily living and instrumental activities of daily living, and mortality. So this is all done with those data sets where we can really tease out what's happening at the individual level. Then we think about the health-related economic outcomes such as work, earnings, wealth, medical expenditures, and then government program participation and benefits. So if an individual if you were able to prevent an individual from developing diabetes, they might be less likely to enroll in disability benefits when they're getting closer to retirement age. And so we would capture those benefits, or not paid benefits. And then we're simulating actual survey respondents, which allows for substantial heterogeneity in terms of the types of analyses that we're doing. So, we can think about subpopulations of interest, high school leavers or minority populations, something like that. The models are fairly complicated. I've got 2 slides on this. I won't bore you with all of the details. I just want to give you a sense that this is a pretty rich thing. And what we're doing is we're really thinking about the pathways of disease. So if you're thinking about, for example, obesity and the impacts that's going to have, that's going to impact a whole host of other things downstream. So it's going to increase your risk for hypertension, it's going to increase your risk for diabetes, and then having those diseases would lead to increased risk of functional limitations and premature mortality. So it has it has a clinically informed causal flow of how we're thinking about disease progression at the individual level. In addition to all the transition outcomes that we're doing at the individual level, we're also thinking about contemporaneous outcomes of interest. So this is medical expenditures, these are disability benefits received, these are Medicaid benefits received, expenses on nursing homes, things like that, as well as measures of quality of life, so we can do quality-adjusted life calculations, and then the actual benefits that people receive from government programs such as OSI, disability, SSI, and other government transfers. In order to think about value and burden of disease, we use counterfactual scenarios. So if a cure doesn't, or if a treatment or a prevention or a treatment doesn't exist yet, we impose that within the simulation to understand the benefits that might be on the table. So the first type of intervention that we would do would to be intervening on the disease progression itself. So this might decrease the likelihood of developing a disease, so this is primary prevention. We might delay the onset of disease, so again, that might be a primary prevention as well. We might slow the progression of a disease, so that's saying you've identified a person who has the disease, now you're doing secondary, I guess tertiary prevention, where you're slowing the progression of the disease and minimizing the consequences, and then also mitigating the impacts of a disease. For example, if you're able to avoid developing diabetes, that might also lower someone's risk for Alzheimer's disease. The other type of counterfactuals that we'll do is altering initial characteristics of simulated individuals. And so there we're thinking about if I had an individual today and I could decrease their BMI, for example, or remove the existence of a disease, I can now simulate the rest of their life and think about the value that might have to the individual. So we often estimate the burden of disease. We think about the value of treatment and the value of prevention. Our different studies take different perspectives on value, and so we think about all of the different components that go into this. I think a lot about individual, so I think about quantity and quality of life at the individual level, their lifetime earnings, and then any costs or benefits, so costs, medical expenditures from living longer or benefits from living longer. We also take societal perspective, thinking about aggregated quantity and quality of life at the full population level, and then cost offsets for fiscal planning. So there, I have a couple studies that I'll show that have some of those results. This slide looks blurry to me. So now I'm going to dive into some of the particular type of work that we do, just so you can get a flavor for what we're doing. So there's been a lot of discussion recently about anti-obesity medications and the potential value that those might have, and also the cost associated with those diseases. So I'll point you to the first panel in Figure 2 that's there, which is the annual lifetime benefit for initiating treatment at a particular age. So I can't quite read off the numbers exactly, but for a particular age group, there might be a lifetime annual benefit of $10,000 for not experiencing obesity. And that's every year for the rest of their life. It's a massive benefit that if we can unlock that, it would be transformative. We also use the microsimulation to think about different groups. So you might think about how you might want to ration or not ration care. You might think about disparities for various minority populations that you're interested in, or disparities by educational outcomes. So in the bottom right panel, you can see that the benefits in avoiding obesity are larger for the high school, those with less than a college degree compared to those with a college degree. Then another type of study that we do is looking at diabetes prevention. And so this is from a fiscal perspective. So this was work that we did to forecast through the year 2050 and think about sort of the strain that diabetes is going to have on future expenditures of various federal programs. So we looked at OASI, DI, SSI, Medicare, Medicaid, and then we also looked at federal taxes, state taxes, and then I'll show you the net fiscal savings. So in a perfect world, if we could flip a switch and say no more diabetes in the future, this is my estimate of the total burden of diabetes. So it's about $2.2 trillion through the year 2050. That's in present value. But you can see that it varies depending on which program you're looking at. So if you were able to snap your fingers and cure diabetes, a program like OASI would suffer because people are living longer, getting benefits for longer. And so when we do our math, we try to account for all of those different effects. But you can see that we know that diabetes is a massive cost for the Medicare program. So I think something like $1 in $4 or $1 in $5 in Medicare spent on diabetes. And so there's significant cost savings associated with better management of diabetes or prevention of diabetes. Similarly, and this is actually a bigger effect, similar results for hypertension. So this is looking at, if you could once again snap your finger and say, well, what if no one suffered the consequences of hypertension? It has a value of about $3.2 trillion through the year 2050. Now, I'm being a little flippant in saying snap your fingers, but this could be tertiary prevention. This could be saying you have hypertension, these are the drugs you should be taking, and this is how to take them well. And patients don't do that necessarily, and so some of those savings can be unlocked with better patient engagement. It doesn't have to be an inexpensive cure. It can be better education of patients. Another study that this one is not yet published, this is in work, is looking at the urban-rural health gap that we've seen in the U.S. So this is thinking about adults age 60 and thinking about the remainder of their lives. And so right now, our projection is that an individual age 60 in a rural environment has about 17.2 quality-adjusted life years remaining, whereas one in an urban environment has about 18.5. I think that's the number. My glasses are a little blurry. Life years remaining. There are things that you can do from a primary prevention perspective for older adults. So if you could have a successful smoking cessation program, these are our projections of what the effects would be. So that 17.2 number goes up to 17.6, and that's narrowing the gap between the urban and the rural health gap. The other point I wanted to make about that is that 0.4 year difference, that 17.2 going up to that 17.6, that's not for smokers, that's at the population level. So that's thinking about the rural population. If you could target smoking successfully, you could potentially have an effect of that size. And then similarly, we do in obesity prevention, but I've already talked about obesity, so I'm going to move on. Another analysis that we did was looking at serious mental illness. So this is thinking about the burden of serious mental illness on 25-year-olds for the rest of their lives. So these are individuals who are diagnosed young with psychosis, schizophrenia, or severe depression. So serious things that have a big impact on lifetime outcomes. And so when we did the math on this and quantified the effects, we looked at the quality-adjusted life years, and you can see that there's this 11.6 quality-adjusted life year difference. That's the burden of having serious mental illness for a 25-year-old for the remainder of their life. Then we also looked at the additional medical expenditures, earnings that were foregone, so it's about $500,000 for an individual. And then we looked at the benefits that they receive from SSDI or SSI. And then there was a clinical trial of an education intervention for young people with serious mental illness, and so we quantified the effects of that. So in total, the burden of having serious mental illness is some number like $1.8 million at the individual level, that's per capita, and this education intervention would reduce that by about $73,000. It's chipping away at the burden, but it is a cost-effective type of intervention. And then I think this is the last study that I'm going to show. We're also doing work, this is also not yet published, this is looking at the burden of adverse childhood events, but this is not thinking about kids, this is thinking about identifying adults who have experienced adverse childhood events, adverse childhood experiences, and then intervening in some way on those individuals once you've identified who they are. And so what we did here is we quantified the impact of ACEs on longevity, quality-adjusted life, and then years spent with various diseases. And first of all, we cataloged the fact that there's a significant burden for individuals who have 3 or more ACEs compared to no ACEs. And then the last piece that we did is we looked at eliminating the effect of those ACEs. So this is something like you can identify someone with ACEs and then mitigate the effects of those ACEs on the particular pathways. And so we looked at the health pathways versus risk pathways versus opportunities pathways. And so this might be something like a counseling program that says, maybe you shouldn't smoke, maybe you shouldn't drink so much, those types of risk behaviors. It might be health pathways where you can identify individuals with higher diabetes risk and intervene on those. And the percentages that I'm showing here are the amount of the burden that you're able to potentially narrow by identifying those individuals and intervening on them with some successful intervention. So in conclusion, I think there's enormous potential in disease prevention, both from a primary, a secondary, or a tertiary perspective. So that's either preventing the disease, identifying it early, or preventing the downstream consequences of that disease. Diseases like diabetes and hypertension are going to weigh heavily on the fiscal environment going forward. I think a broader perspective on value helps to quantify the full benefits and costs of prevention. So if you're, I realize that we're probably very focused on Medicaid programs, but if there's cost to Medicaid and then it's offset by value in other places, I think from a public policy perspective, we need to think about it from that perspective. Identifying the high benefit groups ex ante is really the path forward to help allocate scarce resources. If you're treating people who aren't responding to the treatment, it might be, those dollars might be spent better elsewhere. And then finally, and this is, I realize it's the last bullet point, but this is a big one, the challenges involved here are big. So getting people enrolled in these types of prevention programs, getting people to adhere to these prevention programs, the actual cost of the program, sometimes they're very expensive, monitoring costs to make sure that the program is working as you expected and you should continue to pay for it. And then finally, the incentives to intervene. So the last point is something about like, you know, sometimes it might be the best thing that a physician could do would be to go on a walk with their patient and tell them that they should adhere to their antihypertensive medicine, but the incentives really aren't there in the medical system. So thank you very much.
All right, Keith?
Good afternoon, Mr. Chairman. My name is Keith Lake. I'm a Regional Director of State Affairs for AHIP. If you're not familiar with AHIP, we are the national association whose members provide healthcare coverage. Nope, it's not working.
Is it still on?
Did you turn it off?
Okay. All right. Again, my name is Keith Lake. I work for AHIP. AHIP is the national association whose members provide healthcare coverage, services, and solutions to hundreds of millions of Americans. And I, too, appreciate the opportunity to be with you today on this panel. And AHIP certainly commends NCOIL for examining this topic. Preventative care is essential to the health and well-being of the people that AHIP members serve. And every American deserves access to preventive care and screenings that can catch conditions early before they progress and can reduce the risk for many diseases. I think that we often think of healthcare as the actions taken to treat illness, disease, or injury. While treatment is a major part of medicine, prevention truly is the best medicine, or as Dr. Oliverson reminded us yesterday morning of the old saying that goes, an ounce of prevention is worth a pound of cure. We've heard from some of my fellow panelists today about some of the drugs that are being used or are in development that help us avoid disease and maintain health. And we certainly are grateful for the drug makers that create these miraculous life-saving treatments and breakthrough cures. But preventative medicine isn't solely about pharmaceuticals. For many Americans, that takes too narrow of a view. As our population ages and chronic disease and comorbidities grow more complex, a proactive approach to prevention is imperative. Things like routine physical exams, cancer screenings, oral health screenings, mental health screenings, and vaccinations, as we've heard about earlier, are key to keeping Americans of all ages healthy and key to identifying potential problems early. By doing so proactively, seeking care and tackling healthcare issues, we can help people both stay healthy and reduce the risk of conditions advancing and requiring additional, oftentimes much more expensive care. Preventive services that are recommended by the U.S. Preventative Services Task Force and the Health Resources and Services Administration, as well as vaccines recommended by the Advisory Committee on Immunization Practices, are already covered with no cost to patients under the Affordable Care Act. In fact, there are over 50 recommended preventive services and screenings available without cost sharing. Unfortunately, the reality is that despite the clear health benefits of preventive care and screening, the uptake of these recommended services remains awfully low. Some estimates put it at only about 10% of adults who receive all of their recommended preventive services. We know that providers have limited time with patients. They may not always fully inform their patients of the preventive services that are recommended for them. And patients also may not know that these preventive services are available to them at no cost out of pocket. In addition, some patients also face social barriers that make it harder to access care. And it's important that we address all of these challenges. That's why I'm excited to share details with you today about AHIP's recently launched coordinated campaign to promote the availability of preventive services through the Affordable Care Act. Just last month in June, AHIP and a coalition of public and private health organizations launched this campaign, which we call our Promoting Health Through Prevention campaign. And the goal of our campaign is to raise awareness and increase uptake of these recommended preventive services. Our initiative will seek to promote the full range of preventive care available to consumers and to empower patients to have the informed conversations with their provider teams that will allow them to access those services. You can see on the slide the full list of the participating organizations that are part of this coalition. And we will be using multiple communications channels to draw attention to several tools, resources, and services that are already available to educate Americans about the importance of preventive services. Health insurers, my members, see firsthand the vital role that preventive care plays in overall health. By working together with providers and community partners through this coalition to promote equitable access to these preventive services, we hope to improve access and high-value care so everyone can get the care they need when they need it to achieve their best health. Thank you.
Thank you. Kate?
Go with this one since I know it's on. Hi, thank you very much for having me. I'm Kate Ross, and I'm with, I had slides. Maybe they didn't make it. It's okay, I can speak to them. I'm with the California Association of Health Plans, and when I was asked to come speak, the question that was posed to me was around what are some innovations, thank you. What are some innovations in preventive medicine and care? What are some effective policies that have long-term effects? And so, I asked around internally, and I checked in with the Department of Healthcare Services with their Chief Health Equity Officer and Medical Officer. I asked a number of plans, and the resounding answer, I'm afraid, is not exciting, but rather fundamental, which is we really need to recenter and strengthen primary care. So less about innovation and more about being really intentional and coming back to the things that we know that work. But I will share some ways that we're working on that and new ways we're approaching primary care as an association or as a plan. So I don't think I need to spend a lot of time sharing what primary care is or the value with you all, but I did pull a few statistics from our communication materials, and there's a link there if that's interesting to you. But there is a shortage. I'm sure you're aware there's a primary care shortage. Access is getting more and more difficult. And so our plans are having to be really intentional about the way that they're supporting their networks and the way they're bolstering. So you're seeing plans make increased investments to their existing networks. Targeting small and medium practices is another approach that plans are taking pretty often. And then a lot of pilot activities. So looking to see what works, what can support our primary care networks. Is it reducing burden by aligning some measures across plans, or working within one plan to create like a single sign-on dashboard, just testing and seeing what we can do to help those providers we have today. Another thing we're doing is we're expanding the way that we reach out, right? So I think the expectation that everyone can come into a brick and mortar facility is not realistic, right? So the first bullet there, the Children and Youth Behavioral Initiative, Health Initiative, we're working on that now. That affects both commercial and Medicaid plans. And all that's really doing is, it sounds simple, but it's taking children in the schools and addressing their emerging or existing behavioral health needs right there at the school, because that's where they are. So it sounds simple, but there's a lot of work connecting a lot of pieces there and making sure we're doing this appropriately. Street medicine, that is often confused with the mobile clinics, but it's different. Street medicine is a benefit. The services are a benefit in Medi-Cal or Medicaid today. So what that looks like someone with a backpack walking through the camps or down the street and engaging with a member multiple times, right? Trying to gain that trust and see if we can at least administer first aid, right? Or later deepen that engagement and get them into primary care. But it often takes a lot of time and a lot of outreach to do so because these individuals may or may not trust that traditional healthcare delivery system. But the next two, mobile clinics and telehealth, those have been around for quite a while, right? And we're getting better and better at using them. So mobile clinics, we are using those to partner with endocrinologists for diabetes management, or using those for cervical cancer screening. So those are some of the ways that we are going out and doing some of those important activities outside of the primary care office, and then looping that information back to the team. And then telehealth, I think you're all pretty familiar with that as well. We got very good at that during the pandemic, but another tool in the suite that we are using, especially for some of those hard to reach or rural members. We're also expanding what we define as a provider. So again, trying to support that primary care physician network by expanding who is helping. Doulas, that's another benefit in the Medicaid space, but a bill just passed this year. So doula benefit services will also be available for commercial insurance here in California soon. Doulas, they are individuals who will provide non-medical support to an individual before, during, or after pregnancy. And again, engaging them, supporting them, helping them understand why it's important to engage with their primary care physician and alleviating barriers to do so. And community health workers is another example I wanted to share with you all. These are individuals who you probably know by other names. They're often promotores or navigators. So these individuals, they have a lot of trust, and so they're very successful in helping educate our members and helping get them engaged into primary care, do some non-medical screenings, all sorts of activities that, again, loop back to that primary care team and address that whole person. So this is short, but I just wanted to provide a few examples of what we're doing. We have others, right? There's a big focus on screening. In Medicaid, we also have what we're calling community supports. So that's allowing plans to order things like medically tailored meals or asthma remediation. So lots of activities, but all aimed at taking some of these things that have always existed outside of the traditional definition of care, folding them in and supporting that primary care team. So thank you.
Thank you. And it looks like we have our first question from Daphne.
Thank you. I'm Senator Daphne Michelson-Janae, and it's more of a statement. I think that as an organization, Mr. Chair, we have the opportunity to be able to lead the country in speaking about and working towards preventative care. And I'm disappointed with the low attendance in this room today because it shows that we as an organization are not talking about it enough, or we don't have a universal understanding that preventative medicine is indeed the cost-effective and humane way to treat our community members. And I would just ask that we as an organization figure out how to have that conversation on a larger scale level so that we can move forward legislation or conversation in our own communities about preventative medicine and the benefits to our population.
So noted. Thank you. Representative Dr. Ferguson.
Thank you, Mr. Chairman. Yes, I agree with you on one level, but I mean, one of the things I've seen, having been in the legislature for 12 years, and hepatitis is the perfect example, it doesn't always save money immediately. Yes, the return on investment long-term sometime or usually is there. Hepatitis is the perfect example. I remember we struggled with who to pay for the medicine for hepatitis C in Medicaid. So I guess the challenge for payers and for legislators who are funding Medicaid programs, particularly for those, I know that the long-term plan is certainly I support as a healthcare person is to save lives and prevent morbidity. But how do we sort of help our colleagues, and how do insurance companies, I guess, rationalize for possibly an increase in cost initially for, if you're treating more people, you're going to have more outlay of cost, even though the long-term return on investment may be the same. And the macroeconomic impact will certainly be better if someone's employed, but Medicaid and insurance don't gain that return on investment income necessarily. So I guess how do we sort of sell this to legislators and insurance companies?
I don't know that I have the perfect answer, but I wonder if this problem has existed, right? It just feels larger as costs grow. To me, it seems as if perhaps we as plans need to do a better job looking at the data, right, from past experiences and just making a case that this is a like experience, right? The cost might be different and the cause might be different, but just continuing to prove how these investments in the end save money. I don't know if that helps, but thanks.
And I would just add, Representative Ferguson, too, that, if you think about who many of my members' customers are, employers who are providing healthcare coverage to their employees, oftentimes, not oftentimes, almost all the time, they're very price sensitive. And while they may understand that cost-benefit analysis, the reality is that a lot of employers, particularly your smaller employers that are in the fully insured group market, they don't have the luxury of being able to think about it from a long-term perspective. They're worried about how they can afford to pay their premium that's coming due now for next year. And they also recognize as well, I think all employers recognize as well, that from a long-term perspective, that's great, but I have to pay for it in the short term, and these folks who benefit, and that's wonderful from a societal perspective, but I may not be the one that reaps the benefit of those savings in the long term when I'm paying for those folks who may not be my employees when those benefits accrue.
Yeah, and I want to make it clear, I'm for saving lives and saving people from being sick, but I do think there's a fallacy out there that that's their immediate savings from these preventive programs, and many times it costs more, at least initially. Hepatitis, hemophilia, I think those are all perfect examples.
Yeah, in my experience, being able to provide policymakers with the ROI number for that kind of investment is the critical piece. So as researchers, we have to produce those numbers.
Representative Hefner.
Thank you, Chairman. Thank you for presenting. Yesterday we had a small amount of time to talk about some preventative help for moms who are pregnant, talking about doulas. We had a very short time to talk about it. But one thing that you guys spoke about was programs. The community healthcare worker is so needed because we build more programs, more nonprofits, have more things out there that no one knows about, especially if you're in rural. The doulas can be a community healthcare worker. I think that would be, instead of being so narrow with one, community healthcare worker can really, a model law for that would be so great because it does more than just one thing. Navigating is huge. Finding out the connections, appointments for doctors, transportation, all those things, and they don't, a designation to keep them, to at least give them a pay so that they can move on in the medical field if they want. Having a designation would be so much better. So those are the kind, instead of the narrow stuff, could help these programs, help you, especially research as well, find people that they can help. But I'm so thankful for talking about this. When we think of preventative medicine, we sometimes don't think about that. You don't know what you don't know, and there's a lot of young mommies out there that don't know what postpartum is. And so having those next steps, and continuing to keep them informed. Another point of early intervention, of prevention is early intervention, which again, the early intervention programs can help so much with our young kids. And these CHWs can connect to some of the really great programs. Oklahoma, we have a great one, Sooner Start. And so I do appreciate you talking about community healthcare workers.
Well, thank you, because I think you bring up a point that I didn't emphasize, which is this is also creating career pathways, right? For these individuals who have always been in the community supporting the healthcare industry, but just not in a formalized way. So giving them a more clear path and vision of how they're part of that care team. So thank you.
Senator Kadur.
Thank you, Mr. Chair. Senator Patty Kuderer from Washington State. So my question has to do with what we've seen over about the last 30 years or so with an increase in our population questioning vaccines, the efficacy, and more people not getting them. And I want to hear from you what you think we as legislators should be doing in order to help rebuild that trust, and what you can do from your business end, especially in the pharma area, since that's what we're talking about. You've got a sizable advertising budget. I think we all know that. Are you using any of that to do public outreach, and what is the message that you are telling folks, and how are you utilizing any of the medical professionals, for example, family practice doctors, to talk to patients about vaccines? Because I think it's alarming what we're seeing, and we're already seeing outbreaks of measles, et cetera, around the country, and it's going to be a bigger problem as we go forward unless we really make a concerted effort, I think, to help rebuild the trust when it comes to vaccines.
Yes, thank you for the question. I'm assuming that was for me. And I would have to say that, unfortunately, the politicization and the villainization of vaccines has only grown over the past several years. That being said, as far as pharma is concerned, we do have an alliance division at pharma that partners with community leaders and nonprofit organizations to have mobile clinics and also mobile education. They also have like STEM days, and so there's a lot of investment in the communities that's happening from the pharma side. But then also our member companies are working with those community leaders as well, as far as award programs, grant programs, and volunteer programs that they're sponsoring via charities and nonprofit organizations, whether that is either the education of young children to get into STEM and then become researchers, et cetera, but then also when it comes to the education of vaccines and its benefits, we're really trying to build out those community leaders and the trust in the community via those people. So that is pastors, that is teachers, that is local nurses. So my colleague Sharon Lamberton will be presenting at the November series there about social determinants of health, and she'll be able to show you the nurse coalitions that she's been able to build via pharma, as well as far as outreach in universities, and then also in veteran communities and others, as far as working towards building trust on a very local level outside of just pharma coming in and perhaps giving a commercial, but going into those communities and staying as well. So there's been a shift within the industry to make longer-term investments as well.
Thank you, and I'm going to go ahead and ask one of my several questions here. Kate, we're going to start with you, and when I ask this is just, I want to give you a chance to hear the other side of what I hear about the backpack program, and give you a chance to respond so that we can hear that other side of it. So, as I've talked to other insurance people, what they say is, hey, the corporate people up here want to do this because it gets people out in the community, obviously helps people where they are. This is a great thing, but when I go talk to my local hospital, we're reimbursing these people and they're not building infrastructure. And so we're taking dollars away from the hospital or the doctor's office that, you know, has a light bill, a water bill, employees. So just if you could just give some comments on the balance between those things.
Yeah, what comes to mind for me immediately, and thank you for the question, is that when I talk to my hospital partners, they express overwhelm, right, and a lack of number of beds, and so I think the goal is not to skirt the hospital funding in any way, and of course we need to continue to support our hospitals, but to ideally avoid these individuals needing hospitalization, right? Because the hospitals have plenty to do otherwise. And so if we can avoid hospitalizations by having the individual get first aid or what have you on the front end, that just allows those hospitals to do other things or meet certain metrics, which, you know, need funding as well, right? This is totally separate from hospital funding. It's just more about capacity and ideally helping to avoid hospitalization whenever necessary. Does that resonate with you, or?
I think that's a great answer. I mean, it all depends on the community, right? Is it a hospital that is struggling to stay open, it doesn't have capacity, versus we're in a place where, you know, there's just not enough care availability, and this opens up another avenue. So I think depending on the community, that's a great answer. But that was the feedback that somebody had given me, and I'm just curious how you would answer that. So I've got more questions, but I'm going to move on, give somebody else a question. So Senator Howe.
Well, thank you, Senator Jeff Howell from Minnesota. The concern I have, I guess the question I have is regarding the difference between rural healthcare and urban healthcare. And is there any study out there with the results, if you have, in what adequately funded EMS systems in rural America, and what that would do to kind of lessen that gap in between the urban and the rural aspect? Because what I'm seeing is our EMS systems are not adequately funded, and my concern is that's leading to that big separation.
It's a great question. I don't have a study off the top of my head. I'm happy to look into it further. Anecdotally, my parents live in a fairly rural area, and I've seen firsthand that the emergency services are just not up to snuff for them. So, yeah, it's an important issue.
Thank you. And you didn't ask me, but I will say in Arkansas, we've passed some pretty, I don't like the word progressive, but because it could put off a political connotation, and it's conservative progressive, but we've given ambulance people a lot more scope to be able to work with physicians in hopes that could provide some, one, keep people out of the ER, keep people out of the doctor's office, but two, then provide some other funding opportunities for ambulatory services or ambulance services. Go ahead.
You know, that actually brings up another, the other piece of that, I guess, we are now seeing that we're putting AEDs on the exterior of buildings to provide more access to them instead of locking them up inside the building. They're in heated cabinets. They've got the automatic connect. They actually have a system that if you call 911, the operator can actually see where the nearest exterior AED is out there. And that's another avenue that I think will vastly improve our success of saving folks in rural America. So,
Thank you. Representative Bennett, you got it? Okay. Any other questions that you saw? Okay. All right. So I don't know that I expect an answer to this, but again, this is intended to stimulate some thought and maybe conversation, things for us to think about. So one of the things I always look at, because this is insurance, right? National Council of Insurance Legislators. So there's this balance between the people who set scope in Arkansas on public health, right, versus the people who are paying for it, and which comes first, the chicken or the egg. But also when we structure the payment method, right? So if we use this 80-20 or 85-15 ratio, the medical loss ratio, are we disincentivizing primary care? Are we disincentivizing preventative care? Because if I'm the insurer and I want to make more money, I'm dependent on that whole pot to grow, right? So is there a way that we should look at structuring insurance that doesn't get rid of that ratio? I think conceptually it makes sense. But is there a way that, hey, we should be looking at opportunities to identify those preventative care opportunities? Because like Representative Ferguson said, hey, it might cost more on the front end, but we hope that costs a whole lot less on the back end. So if anybody who wants to take a shot at that, I'd appreciate it.
In the spirit of discussion and not answers, to me, that just brings to mind the need to really be thoughtful and flexible when we're defining the numerator and the denominator, right? And to take learnings, unintended consequences, and be willing to adapt. But it's a great question. Thank you.
And I think that was really what I intend is to make that point, because we think about that, or we've structured it in such a way. I understand conceptually it makes sense, but I ask myself, are we incentivizing the wrong things because of that structure and without any ways to address this preventative care? So the other thing, more of a comment, but we talked about shortage of primary care, and I want to be careful again because we're in insurance, but and Blue Cross Blue Shield of Arkansas has started paying pharmacists for some primary care type services, and I think that's innovative on some level. Other states have adopted that. What I don't know is, have other states, the insurance company, gone out of its way to start paying for some of those, like what I would refer to as test and treat, or smoking cessation, things along that line that y'all know of.
Senator, I don't know the specific answer to your question. A lot of our members have done a lot to try to be supportive of pharmacists, and particularly your independent and community pharmacists, and to raise, to encourage the provision of additional services as well. But I don't know, I can't give you specific examples of that. But I know that is certainly an area that some other plans have also looked at.
Thank you. Representative Dr. Ferguson.
Thanks. Justin and I are friends, obviously, from Arkansas, so he knows this is kind of my concern. Every time we have the tobacco settlement, people come. And Arkansas is unique in that we actually spend tobacco settlement money on medical services, or related medical services. But, they want to come and brag about how we've reduced smoking and all that every time. But then and actually the New York Times came to a town near my Delta and did a long story. We've really not moved the needle on smoking in Medicaid and low-income populations at all. So, do you have strategies to help do that? How do we address that? Because it is really one of the biggest health challenges for places like I live in the Delta.
That's really fascinating, and I would love to actually get back to you on that. So thank you very much for the question. For us in California, what I know is that we had a fairly successful public health campaign, communication campaign, and as a result, that money we get from the taxes, for the cigarette tax, it's actually, it's been reducing every year, where we're having to supplement it from other sources of income. So to me, that sounds like a measure of success, right? That smoking cessation is happening. So let me dig into why, what worked well here. But I will just add that I know most, if not all, of our plans here in California have smoking cessation education and campaigns and lots of different types of incentives, because that does have such adverse effects on someone's health. And so it is in their best interest to have their members quit or never start smoking.
Okay, seeing no further questions, when this session is finished, thank you everyone for participating. We really appreciate it and look forward to part 2 of this series in November. Up next is the meeting of our Life Insurance Committee in this room. We will take a quick 5-minute break and then get started. Thank you again.